Trevor,
Yes, okay.
the floor is yours.
Yeah, I've been blessed with some wonderful graduate students, and Marjan Biria is just one of those. She's been undertaking a very ambitious project looking at the interface between schizophrenia and OCD in the context of these bizarre side effects of clozapine therapy. And she's been focusing on a single aspect of compulsive behavior, namely checking, and hopefully also exploring the neural substrates of this symptom. Nevertheless, of course, as we all know, the pandemic has struck, and it's been very difficult in her final year to recruit the requisite number of patients for the imaging studies. So she's going to tell you a bit about what she's achieved nevertheless in this, I think, quite impressive presentation. Thank you.
So as Trevor mentioned, my PhD project has been about understanding the obsessive compulsive symptoms in schizophrenia patients who are treated with clozapine, which is a second-generation antipsychotic medication. So about 25% of patients with schizophrenia, they also meet the diagnostic criteria for OCD. And unfortunately, these patients, they tend to have a more negative prognosis, such as higher positive and depressive symptoms, reduced social functioning, and a greater suicidal risk. So we also have the drug-induced obsessive compulsive symptoms. So throughout my talk, I'm gonna abbreviate the obsessive compulsive symptoms to OCS. And by far, the highest rates have been reported for clozapine. About 47% of all the clozapine-treated patients, they also experience OCS, which is a very high number. And this works possibly through these serotonin receptor antagonists. So it is also very important to note that the OCS severity impacts patients' well-being significantly, and that is independent of their schizophrenia symptoms, the positive and negative symptoms. So despite the importance of this issue, there have been only a few studies on the impact of this comorbidity and who is at a higher risk. And that is why we thought this is a very important topic to study during my PhD. So the objectives of my PhD were to understand the brain mechanism of obsessive compulsive symptoms using this name might sound difficult, but I'm going to explain to you what it is. It's a special type of scanner called magnetic resonance spectroscopy. And what it does, it looks like an MRI scanner, but it measures the neurochemical abnormalities. And we have a very powerful scanner in Cambridge at 7 Tesla, which means that we can measure data more accurately. So I will also use fMRI, some fMRI data to look at uncertainty, the responding to uncertainty, which is also important for obsessive compulsive symptoms. But I also have a behavioral project to look at the neuropsychological mechanism underlying the obsessive compulsive symptoms in schizophrenia patients, comparing it with OCD patients, healthy volunteers, but also pure schizophrenia patients without obsessive compulsive symptoms who are also being treated with clozapine. To do that, I used a battery of different cognitive tasks. 3 of them were developed by myself, but today I will be focusing only on one of them, which measures checking behavior. And the reason for that is because checking is one of the most important symptoms in obsessive compulsive in schizophrenia patients who experience OCS, but also in OCD patients. And when I started my PhD, we didn't find a reliable task to measure this important behavior. And that is why I decided to design and develop a new checking paradigm. So today I will be only talking about the results of this checking task. So this is how the task works. Participants will see 2 black and white drawings of objects displayed one after another. And what they have to do is to decide if these 2 drawings of objects are the same or different. And there can be differences either in size, in angle, or they can be completely 2 different objects. It's a touch screen task. So when people think these 2 images are different, they can press on the word different on the screen. When they think they are the same, they can press on the word same on the screen. But before giving an answer, they also have a chance to press on this icon and go back and look at the images again. And this is how we measure checking behavior. After giving the answer, people also have to rate how confident they are about their answers. And this is also related to uncertainty. There are different components in this task. There are 4 different blocks, each of them measuring different components. In block 1, people don't know how they are doing because they don't receive feedback about their answers. They don't know if the answers were correct or wrong. This creates uncertainty. In block 2, feedback is optional. We can also look at the relationship between sensitivity to negative and positive feedback. In block 3, feedback is always provided, but this time people get punished for checking. And we can see who are the people that continue to check despite being punished for it. And in block 4, we can look at, we can answer the question whether checking is habitual or not. But today I will be focusing only on the block with no feedback and the block where people get punished for checking, and try to look at this functionality of checking behavior. So I'm going to show you some results now. So there are some similarities between the 2 no OCS groups, healthy volunteers and pure schizophrenia. So when we look at the relationship between confidence and rate of checking, we can see the 2 no OCS groups are very similar. They don't show any relationship between these 2 measures. But we can see that the 2 OCS groups, OCD and schizophrenia with OCS, they show a negative relationship between confidence and checking. So the less confident someone is, the more they check, or the more confident they are, the less they check. So this was a measure within the task. Now, if we correlate the measurements of confidence within the task with self-reported checking answers on an obsessive compulsive inventory, we can see the same patterns. And this is a very consistent finding because we can see that across all 4 blocks, and we can see that these are in purple and in green. We see the 2 OCS groups, schizophrenia and OCD. In red and in blue, we see always the healthy volunteers and schizophrenia without OCS. We see that this negative relationship between confidence and OCI checking, the OCI checking subscale. So it's the same between the measurements within the task, but also the self-reported measurements. However, there are also differences between these 2 groups. And when we look at the intolerance of uncertainty as a trait and its relationship with checking rate within the task, we find a positive correlation between the intolerance of uncertainty and checking behavior only in OCD patients. So it seems that OCD patients, they are more sensitive to uncertainty, but it is not the case in schizophrenia patients with OCS. So another difference between these 2 groups is that checking seems to be dysfunctional in schizophrenia patients. So what it means is that in OCD patients, where checking seems to be more functional, we see that checking improves accuracy of answers. So the more someone checks, the better, the more correct their answers become. And this is also a very consistent finding because we see that across all 4 blocks. Now, lastly, clinically, the checking task seems to be validated by the fact that the checking rate within the task is related to real-life checking compulsions, or in general, obsessive compulsive compulsions measured with Vibox, which is like an interview performed by the clinicians. But we don't find this in schizophrenia patients. This might be because Vibox is not a good measure to measure the obsessive compulsive symptoms in schizophrenia patients, because they show the positive symptoms, and it's very difficult to dissociate the obsessive compulsive symptoms like intrusive thoughts from positive symptoms and like delusions. And I think we need a better measurements of obsessive compulsive symptoms in schizophrenia patients. So to conclude, the checking task successfully can distinguish checking abnormalities in both OCD patients and schizophrenia with OCS. There are similarities between the two groups related to confidence and checking behavior in both of the groups, but there are also differences between the groups. So intolerance of uncertainty seems to be a trait in OCD patients that is related to checking, but this was not the case in schizophrenia patients. Checking seems to be more dysfunctional in schizophrenia patients, and this might be related to other factors than the factors we find in OCD patients, such as uncertainty, intolerance. So it might be related to their deficits in making decisions. And lastly, YBOX seems to have limited utility at characterizing the severity of obsessive compulsive symptoms in schizophrenia. And we do need a better way of measuring these important symptoms in schizophrenia patients. So I also wanted to talk to you about other projects that we have. And so these findings that we have, we are also interested to find out more about the brain correlates of them. So we do that by using the 7-team MRS study that I told you at the beginning, looking at the neurochemical abnormalities in a region that we think might be important for checking and decision making. This is just an image showing the really amazing data quality that we managed to get after our 1.5-year pilot study. In black, we have the in vivo measurements, and in red, we have the fitted model. And we can see that these two lines, they fit so nicely that we almost don't see the black line anymore. And this shows the good data quality that we get. But we are also interested to look at the brain function in response to uncertainty. And I'm also analyzing the data set to look at the structural features important for OCD symptoms. And I forgot to say that I've also done a literature review on PET and MRS findings in OCD. And the results are published as a book chapter, but also as a journal article. I'd like to thank all my supervisors and everyone else who has helped us in this study. And of course, Mental Health Research UK for funding my PhD and supporting me in my PhD journey. And of course, thank you all for your attention.